we are honored to welcome Ms. Adilia Amirulhusni Alshukor. She graduated with Master of Physiotherapy endorsed in Sport Physiotherapy from University of Otago, New Zealand in 2006. And she obtained her Bachelor degree of Physiotherapy from UITM in 2012. And Adilia began her career as physiotherapy with Pantai Integrated Rehab Services in 2013. And she has been based at Pantai Hospital Kuala Lumpur and Pantai Hospital Klang. She has also worked with DMC Specialist Hospital, Shah Alam, upon returning to Malaysia in 2016. Currently, Adilia is a senior physiotherapy in musculoskeletal subject matter, and she is an expert in musculoskeletal clinical instructors with Pantai Integrated Rehab Service in Berhad. And her area of clinical practice is in outpatient musculoskeletal, specializing in sports, injury rehabilitations, orthopedic manual therapy, and returning to activity or play progressions. Adilia have a keen research interest in sports injury prevention and management within the active population. She is also a member of Malaysian Physiotherapy Associations and Malaysian Association Sports Medicine. Without further ado, Adilia, the platform is yours.
Okay, hi everyone. So I'm just gonna share. Thank you for the introduction, Dr. Ida. Haven't seen you for a while, so that's nice to see you. Okay, I'll just share my screen and then let me know if you guys can start seeing it. Right. Okay, can you see it now?
Not yet, maybe it's coming. I'm not sure about the rest. Participant, can you see any slide coming out?
Not yet.
Not yet, okay. We give it some time. Okay,
now.
yes, Adilia is coming.
Yeah.
Okay, awesome. All right. So, good evening, everyone. So, as Dr. Ida has mentioned, my name is Adilia. So, I'm actually an alumni of UITM, has graduated in 2012. So, the topic that I'm going to be talking about today is principles of tendon loading for tendinopathy management. So, I am a clinician full-time. So, I have currently not working on any research background, but I have a keen interest in tendon injury management. So we're going to start off with a little bit of an introduction of the normal clinical terms that we have. All right. So I'm sure when you receive a referral from doctors or outside clinic or patient coming in with pain saying that they have tendinopathy, they have tendinitis and tendinosis. So what actually is the difference between all these clinical terms? All right, so first of all, we're going to start off with most of the terms I'm going to be using for this session will be tendinopathy. So basically, it is a clinical presentation of pain in a tendon with resulting dysfunction. Okay, and then, so you might have received tendinitis. So this difference in terms will also affect in terms of patient's confidence to you. They will ask you whether what is tendinitis and what is tendinosis, what is tendinopathy. So is it different or is it the same? All right. So tendinitis itself.
Adilia. Sorry,
Yes?
Adilia. Can you just hide the UITM WebEx panel down there? Thank you so much.
All right, sure.
Thank you.
Let me go back there. Wait, no, it's all right. Is it back on my slides? So I continue now?
Yes, yes.
All right. Okay, so from there, tendinitis, if you notice the last few alphabets is itis, is inflammation. So is this really an accurate representation of a tendon injury problem? So the description or the definition itself is inflammation of the tendon resulting in micro tears when the musculotendinous unit is acutely overloaded with tensile force. Okay, so we're going to challenge this term later on as we go. And then we're going to move on to the next term, tendinosis. So what is tendinosis? Some people will say that it's actually like a cell death but it also can be known as a degeneration of tendons collagen in response to chronic overuse. All right, so from here, we're going to move on to our to the next slide. So I'm just going to give you guys a brief overview of the general tendon anatomy and function. So we have the tendon, it attaches muscle to bone, so I'm sure everybody knows that. And then we have, it's made out of mostly of collagen type 1 fibers and proteoglycans. So the collagen and the proteoglycans are responsible for tensile strength and the viscoelastic nature of tendon. So basically collagen fibers are responsible for the tensile strength, that the energy storage properties of a tendon, and then the viscoelastic, that means the elasticity of your tendon, is provided by the proteoglycans. So it can vary in shape and size depending on muscle function. I'm sure a lot of us see a lot of different type of tendinopathy out there. We have upper limbs like supraspinatus, lateral epicondylitis, and we also have Achilles tendon, patella tendon, and then even plantar fasciitis is also can be argued that is part of is actually a tendon. Okay, so the function of a tendon is transmit force generated by the muscle to bone in order to elicit movement. So the tendon, because of its very important function, it has to be very strong and it has to be very stiff for it to be able to withstand all the force that is being generated by the muscle and then to bone. So this is, and then that's where the how do you say, the conditions happen. So whether they have a sudden loading or like the tendon itself is not strong enough to withstand these forces. Okay, so I'm going to move on to the next one. So this is another photo. So we have the muscle belly there, and then we have the myotendinous junction, the tendon and antisis and bone. So tendinopathy can happen at any area, any of these areas in the for the tendon. So it could be at the myotendinous junction, it could be at the free tendon over here, and it could be at the antisis itself. All right, so we're going to move on to the next one. So what is the difference between a normal tendon and a pathological tendon? So, like we have seen in the previous slides, we have tenocytes, which is basically the tendon cells. In a normal tendon, the histology photo will show that it has low cell numbers and the tenocyte appears to be small and flat. Okay, and then the proteoglycans are minimal, and then the mechanical sensitivity of the tendon will be, it is sensitive to mechanical load, but it's also reversible. For instance, when you have the tendon will show that there will be some increase of size after a bout of exercises, but after 24 hours, 48 hours, it will reverse in size. So that's when you say it's still reversible. Okay, and then the collagen arrangement, if you notice in the picture with the A picture, you will see that it's quite nicely arranged, it's unidirectional, and it consists of a type 1 and type 2 collagens most of the time. And the structure of the matrix as well is quite well maintained. And you also will know that there is minimal vascularity in a normal tendon. So even if you see even the colors of the tendon, the muscle itself will be very bright red. And then what is the color of your tendon? It will be white, right? So that shows in terms of the vascularity, there is less vascularity. So how does this implicate the pain? How does it implicate the function? Or in terms of what are the difference in the pathological tendon itself? Okay, so these are the questions that we need to ask ourselves. All right, the next one, we see how pathological tendon. So in the pathological tendon, you will see that there is a cells proliferation observed. That means the cells numbers are a lot more compared to the normal tendon, and then even the shape of the tenocytes, which the tendon cells, are also appears rounded. And then the proteoglycans are large. If you see all the little, if you can see some of the images there, that they have these little round structures. And then the mechanical sensitivity of a pathological tendon, which we will talk more about later, is sensitive, but it's limited. It has limited capacity to reverse back towards the initial arrangement. And then the next difference is there is some type 3 collagen, and then there's a disruption of matrix structure. So if you notice in the pictures, it's not unidirectional anymore. So there's also some vascularity. And then if you see, some studies will show that there is an evidence of angiogenesis in a pathological tendon as well. Okay, so that's the difference for the normal tendon and the pathological tendon. So we're gonna move on to the next one. So this is another image of the difference between normal and abnormal. So actually, I wouldn't like to use the word abnormal, but this is it is in the photo here. But what we want to see the changes there. There's an increased cellularity and the mild fibroblast in the pathological tendon. There is neo vessels. So the neo vessels is what I mentioned just now in terms of vascularity, which is not so evident in a normal tendon. And then there's an increase in matrix protein, and then the arrangement of the collagen fibers are also in this array. So you see the cylindricals or the fibrils of the normal tendon is always nicely packed, and then but in the abnormal tendon it's not organized anymore. Okay, so next. So these changes occur in tendon structure. But the question now is how does it happen, or why does it happen in the tendon? Okay, so we're gonna move on to the next one. So there are several pathoetiological models that in tendon injury. So what happened actually in the tendon? Why is there so much difference between the pathological tendon and compared to the normal tendon? So I'm gonna start off with the first one. So the collagen disruption and tearing. So conventionally, people think when there's an injury at the tendon, there will be collagen disruption, there will be tearing of the muscle, and eventually there will be remodeling. But this is actually the oldest model that has been mentioned in the literature. So, but it can be challenged, because if it's saying that a collagen can be teared, because the collagen is actually a very, very strong structure. So it doesn't get torn easily. Before the collagen gets torn, usually the muscle will get torn first. All right. So it can be challenged because the normal collagen can't tear without alteration in non-collagenous matrix. So what does this mean? It means that for a asymptomatic tendon to be torn or to be ruptured, they could already have an underlying pathological condition. So just unless it's a tendon cut and you have like a knife injury, so that one is definitely normal collagen can be torn. But for normal people who has no symptoms and suddenly they wake up and they had a rupture, usually 80% of the time they will have already a pathological tendon without realizing it or with no symptoms. So, and then the other challenge in this model itself is that it has the limited reversibility in degenerative tendon pathology. What does this mean? So that means that if you are saying the collagen will disrupt and then it will remodel, but then when I will explain later, when the tendon is already in a degenerative mode, it won't be able to reverse back unless it is in a reactive period. And then therefore, and then there's a lack of remodeling following exercise-based intervention. So in exercise-based intervention, what happens is sometimes the tendon gets thickened because the collagen gets, there's more water that goes back into the collagen, but that is usually reversible. But if the causes of the injury is a disruption or a tearing, is not evidently show that all tendon will remodel after an exercise intervention. Okay, so the next one is the famous one. I think people will always explain. This is what a lot of people explain to their patient: inflammation. What happens to the tendon? When patient asks you, what happens to the tendon? Why is my tendon swollen? Why is my tendon? Why do I have pain in my tendon? So usually in this model, it will say that there is an increased inflammatory cytokines in overuse tendinopathy. All right, so when they check, there is an increase in changes in the inflammatory markers in the pathological tendons. So this is what is supporting this model actually. But other studies would have said that actually this inflammatory response is actually the tendon cell itself. So what the changes that happen in the tendon cell itself, which causes these inflammatory cytokines or inflammatory markers to be raised. And because another thing that is important in this part is that the changes in markers in tendon, in pathological tendon, is that it occurs in response to cyclic load. So what does that mean? It means that when there's a mechanical overload, there is a mechanical load, the markers will increase. But when there's no mechanical overload, then the markers reduces. So this actually why people hypothesize that this is not the most accurate model for tendon injuries. Okay, because the tendon cell signals is always response to mechanical stimuli. So the next one, we have the tendon cell response. So the tendon cell response model goes by saying that it says that the tenocytes, the tendon cell, is primarily responsible in maintaining our extracellular matrix. Okay, so what happens is that changes in the tendon load and biochemical chemical environment results in a cascade of response by the tendon cell itself, which is why when you notice that a tendon pain, if it's really a tendinopathy, patient will always complain of a localized pain. So they won't have a diffuse pain or anything, but the pain will be exactly at the tendon itself where they have it, a very, very specific localized point. Okay. And then what happens also is that in the tendon cell response, other than the changes in the response in the tendon cell can also respond not favorably. So when you have a compressive loads in the tendon, you can cause a fibrocartilage development. Okay, a fibrocartilage development. So fibrocartilage development is not what we want. We want it's like a scarring. So but we want the changes the tendon needs to be stronger. All right, so I'm going to move on to the next one. So for the purpose of this study, we're going to talk more on the tendon cell response. So basically this is the model that I'm going to base a lot of this, the talk on today. So what is the next thing? It is a tendon injury continuum. So like when I mentioned in the title, this is the principles of tendon loading. So because the tendon cells are quite responsive to mechanical load, so this model has been introduced by Jill Cook and Craig Purdom in 2009 to show that the tendon injury, you cannot actually classify it into one or three areas. It's actually a continuum. So where the patients are in the tendinopathy depends on where they are in the continuum. So for instance, we're going to talk a lot more here. So when they have a stress shield, there is the normal tendon, there is the reactive tendinopathy, and then there's a tendon disrepair. And then lastly, there's a degenerative tendinopathy. So the tendon can adapt when they are in their normal tendon period, and they can adapt when they are in a reactive tendinopathy period. Okay, so for instance, a normal tendon that has been unloaded can suddenly receive a moderate stress on it. For instance, a sedentary patient who has not done lots of exercises, strengthening or any lower limb based exercises, and then the activities are mostly computer based, desk job and everything, can experience a rupture or can experience a reactive tendon when there is a change of activity. For instance, nowadays a lot of people are stuck in their homes, and then all this while when they were working, they don't go for walks, they don't go for jogs. But suddenly, because that's the only type of activity that is allowed now, then they will start going for jogs and they start going for frequent brisk walking and everything. So, but then their tendon can be hypothesized to be an unloaded tendon, and then they start going walking every day. And then what happens is that it becomes an excessive load. So when it becomes an excessive load for the, depending on the individual factors as well, it becomes a reactive tendinopathy. So when when the patient comes in with you after walking for 2 weeks of every day of maybe 5K jogs and everything, they might come to you with a pain. So, but if they are in this reactive tendinopathy state, there is still possibility for us to, regress it back to a normal tendon. All right. So we have to modify the loads, and when we modify the loads, the tendon structures can go back to the normal tendon. All right. So, but what happens when the reactive tendon has undergone chronic overload over time? For instance, and athletes like a football athlete that has been training for 6 months, and then suddenly they have an off season for 1 or 2 months, and they go back and rest. So during that rest period, their loading are not similar to the ones that they have during their training, during their season. So what happens then when they go back to training? When they go back to training, it could be that they already have a chronic overload at their tendon. They might already have pathological tendon, but when they change their activity and come back to training, it could be another reactive on top of a degenerative tendinopathy. So I'll explain that more in the next slide. So for this instance, so when they go into a tendon disrepair, there's not much you can do to change the structures of the tendon anymore. So because it's already what you can consider tendinosis, so cell death, and then there's no reversibility anymore in a degenerative tendinopathy. But a degenerative tendinopathy can have a reactive tendinopathy as well. So on top of the degenerative tendinopathy, they can have a recurrent episodes of pain. Okay, so we're going to move on to what I mentioned about just now, reactive on degenerative tendinopathy. Okay, so that's what, when we see this structure here, the degenerative portion of the tendon it has limited reversibility, and then you can't really change the structure anymore, but it can be painful. Some people can have a degenerative tendon which are painful, but they can also have a degenerative tendon that is asymptomatic. So there's a normal portion of the tendon itself. But what happens for some patients is that they have been a marathon runner over maybe 1 or 2 years ago, and then they started increasing their distance. So a marathon runner, usually they will train quite regularly, and then depending on their load, stimulus and everything, the tendon could already have a chronic overload. So what happens when they change their training, instead of 21 kilometer, they will increase to 42 kilometer in between 1 month or 2 months. So that can induce a reactive on degenerative tendon. So patients who have already had a pathological condition, and then they have a new onset of a reactive portion of the tendon. So a new onset of pain, a new onset of functional problems. Okay. All right. So we're going to move on to the next one. So I'm not sure if any of you have heard of this. Maybe some of you have. Treating the donut and not the hole. All right. So this is a structure. This is a, how do you say, is a verb that they use in describing the management of tendinopathy. So I'm going to move on to the next one. So what does it mean? So imagine the donut is actually your tendon. So the round area where all the breads are, where all the good stuff are, is an area of all the aligned fibrillar structure, which means, like we saw just now in the image, is actually where the tendon itself is still reactive. But the whole of the donut is an area of disorganization. And to put it simply, that will be the unhealthy structures of the tendon. And then the donut itself is the healthy structures. So because of the characteristic of the tendon cells which responds to load, this is where we should be treating instead of trying to change the structure of the whole or change the structure of the unhealthy portion. Okay, so we're gonna move on next. So tendinopathy management strategies. I'm sure a lot of people are very familiar with all the conventional treatment of tendinopathy. For instance, some people will get patient to rest, they will get patient to stretch, which I get a lot of patient who comes to us that sometimes patient, all the treatment that they have been done is all pain management modalities, all sorts of shockwave therapy, ultrasound, ice, hot packs, and all that. But are you doing anything to change the tendon structure itself? So how, if you are able to manage the pain with the pain management, but is there any, the patient will still come back with a recurrent episode of tendinopathy. Okay, so we're going to move on next. What not to do is asking patient to rest. I think even a lot of doctors as well, they will also ask patient to rest. That means they are really offloading the tendon itself. So part of the tendinopathy management is load monitoring. You need to monitor the load and you need to reduce a provocative load, but not complete rest. So what happens to the structure of the tendon when you prescribe complete rest to your patient and just pain management? You have a risk of underloading the tendon and causes changes that are not favorable to what we want. We want the tendon structures to be stronger. You want it to be stiffer for it to be able to tolerate the loads of the activities for walking, running, jogging, jumping, and all of that. This is for lower limb tendinopathies. Even for upper limb tendinopathies will be like, throwing activities, overhead activities, all of that. So if you ask the patient to rest, then what happens to the structure of the tendons? It becomes underloaded, and then suddenly you send the patient back to the sports, or you send the patient to start going jogging again without any progressive loading of the tendon. So it's very important to educate your patient why they should not be completely resting and the tendon. Okay, and then the next one, what not to do, stretching. This is a very, very common thing that is being prescribed to patients, that they tend to, for Achilles tendon or plantar fascia, I get patients who have been taught how to stretch their tendon. And then why do you need to stretch the tendon? What happens when the tendons are being stretched? So the tendon it responds well to tensile loads, but then when you apply a compressive load, it gets more irritated, it gets more angry, so it doesn't get better. So when you, for instance, you do a ankle stretch on a plantar fascia, so the load that is applied to the tendon itself is a very compressive and it's a very, very irritating kind of load. So you're not getting the tendon cell response that we want, and you might even causes the development of like fibrocartilage at the area. So some tendons wrap around it, like for the heel, like Achilles tendon will wrap around the heel and then goes down to becoming the plantar fascia. Then over time, it can be causing the development of fibrocartilage, which is not the response that we want from the tendon cell itself. Okay, so for this presentation today, I'm just going to talk mostly about active rehab. So there are a lot of other treatment with tendinopathy, like the medical, the corticosteroids injections, PRPs, and then, but for the purpose of this presentation, we're not going to talk about that because those are actually not even part of our physiotherapy management. Okay, so next, what can we do? Yes?
We have another 5 more minutes, Adilia.
Sure, okay. All right, so, so next one, we have, what are our options? So our options are not ultrasound, pain management and all, we can actually do so much more. We can do a lot of load management. We can do isometric exercises. We can do eccentric exercises. We can do high slow resistant exercises. Okay, so we're going to move on next. Load management. What does it mean by load management? So we need to be doing a thorough history during our subjective assessment. And this will indicate the possible trigger of the mechanical overload. So when you identify the loads volume and types, for instance, the easiest one that I have mentioned before also is jogging. So if they have been jogging 5 kilometers every day, that could be possibility of the mechanical overload. So how do you manage that? You advise the patient to, reduce down the intensity, reduce down the volume, and then you reduce the provocative load while you build up your strength. So how you build up your strength? That's when the other exercises come into play. But with load management, you have to consider extrinsic and intrinsic factors. For instance, age, gender, diabetes, and hypercholesteremia. So all of these will contribute to the tendon changes in itself. All right, so sedentary individuals might have a chronic underload, which the pain can be triggered during moderate mechanical overload. All right, so if you are underloaded, when you give a moderate load, then it can also trigger their tendinopathy. So next one, isometric exercises. So the interesting part about isometric exercises is that you can get pain benefits. It has been shown that it has analgesic effect lasting about 45 minutes in patellar tendinopathy, in Achilles tendon. But these effects is the pain might come back after that, but it's good. It's a good modality to use as the beginning, as during your first session when the patients are very reactive, in a very reactive state. Okay, so but in upper limb tendinopathy, the similar effect has not been observed. So the isometric exercise has its place in terms of pain, and it can be used early in rehabilitation program. Okay, next, eccentric exercise. This is quite famous for tendon loading because the idea is that the eccentric movement itself will give a specific load to the tendon. So there has been shown to improve effects of collagen production, but it's also mostly done in isolation. So the non-favorable effects of eccentric is sometimes you can cause a lot of muscle soreness as well. And then, is it really strengthening the tendon? Yes. Strengthening or stretching effect, or is it applying a compressive load instead of a tensile load that we want? So an example of it that you guys can have a look later and research about it is Alfredson protocol. It's a bilateral heel raise and an eccentric lowering of heel raise for Achilles tendon. So next one, the high slow resistance. So the high slow resistance exercises involve both concentric and eccentric contraction. It has been shown to have better outcomes when compared with isolated eccentric program in terms of function, in terms of pain, in terms of strength and endurance. So what it entails is actually the isometric exercises which are being used initially, and then the next stage they will use the isotonic exercises, and then they will move on to the energy storage exercises and consecutively go to progressive return of spot to spot. Okay, so an example of that would be Silbernagel's protocol, where they use for Achilles tendon. So they use this isometric and they use this mobility, increase the concentric and eccentric. They uses the concentric protocol, they uses the eccentric, and also there's a plyometric component to it. So this is actually a very good example of a protocol for Achilles tendon. So how you can use all of the exercises in conjunction. All right, but this is only the guideline. So the key principles for a tendinopathy management is actually you need to be loading the tendon. You need to be progressively resistant the training, so to get the changes in the tendon itself. And then because of the changes of the production of collagen takes time, usually studies have shown that it needs to be consistent for up to 12 weeks or more. So you need to educate your patient why they need to continue their exercises and why to get the changes that we desire. And then we also need to monitor the pain, because some of the exercise for eccentric or concentric, there might be some pain in the tendon itself. But how do you monitor it, and what are the levels of the pain that is done during the exercises. And you also need to monitor the 24 hours response, whether you are overloading the tendon and making it more reactive, or are you underloading it. Okay, and the
yeah,
most,
you have 1 more minute, sorry.
yes, all right, it's okay. Last sentence. All right, so the most important, well, look at the patient in front of you. Don't look at just the tendon. It is not a recipe. Even if the protocols that we shared today is not something that will be applicable to all of the patients. It will be something that you need to individualize. Don't use a recipe to treat the patient. So because when you do that, that's when you get the compliance, you get the continuous progressive resistant training. Okay, all right. So that's all from me today. So if you guys have any questions, and then we can try and answer it for
Thank you
you.
so much, Adilia. Yes, it was a very interesting sharing sessions. Interesting to know the loading regime principles for the tendinopathy. Okay, I think we have one question in the chat box.
Right.
It comes from Saiful Adli. Is there any specific loading treatment regime for acute patellar tendinopathy?
So I think the Alfredson protocol that I mentioned just now is one of the protocol that we can use for patellar tendinopathy. So basically, they get patients to stand on a decline board and maintain the position for about 45 seconds and for patellar tendinopathy. I think it's isometric, right? The question.
Regime. Is there any specific
Acute.
regime?
Yes.
Yes. Acute. Yeah.
And also there's actually recently there's been some studies that have compared the isotonic and the eccentric regime. So you can, I think it's Postgrad 2019, so you can have a look. Maybe I can share to you the article later. That will show.
Thank you so much,